hypertension and aging-related SADB. Please, Dr. Norving, there you are. Thank you very much.
So, thank you very much, and thank you very much for the invitation and the organization of this just wonderful meeting. I'm very, very happy to be here. I will drop the historical details when I heard about Cadacil for the very first time. I will do that privately for you later. I will go to my talk and turn this around. I will leave now the genetics. I will speak about sporadic small vessel disease. I will speak about it in relation to diagnostics and risk factors, and in particular in relation to hypertension and to age. Is hypertension important? Well, of course it is. This is the slide from the very recently published 2010 Global Burden of Disease Study, a landmark publication in The Lancet, December 15, showing the mortality, the disabilities, the risk factors globally. Is an extremely important paper, and which is the #1 risk factor overall in the world. It's no surprise that now it is hypertension. You see the color line which indicates cardiovascular disease mainly. This is #1, tobacco smoking. On the second one is the single most important risk factor globally. And you can see here in this series of papers is a comparison between the situation in 1990 compared to 2010, and what has happened in these 20 years is that high blood pressure have increased from the 4th position up to the top position with this relative increase. So clearly we have hypertension, we have smoking, globally the most important risk factors. This is a fact that is very important in very, very many circumstances. So age, these are also, I think, two extremely important and fascinating numbers from these publications. What has happened in the world over 20 years with the life expectancy in the world. In just 20 years of time, you see that the life expectancy in males have increased 56 years to 67 years, 61 years in females, up to 73 years. Is a remarkable change in 20 years of time. It's unbelievable, really. And we see a very rapid change in the situation of diseases in the world. You can calculate what is the total burden of disease in the world 1990 compared to now. It's very surprising that despite the increase in population, it's the same burden of disease 1990, 20 years later. Why so? Because the population has been healthier. Infectious diseases has gone down, and still now the risk is of non-communicable diseases, heart disease and stroke, to increase, which really needs actions. So this is the introduction. For stroke in general, hypertension is also the single most important risk factor. As we know, this is from Interstroke study published in Lancet 2010, and two major findings: 10 modifiable risk factors explain 90% of all stroke, and importantly, the population attributable risk for hypertension was almost twice as high for stroke than for heart disease. So for stroke, really very, very important risk factor indeed. So is it important for lacunar infarcts then? Well, of course it is, and I will not burden you with all the data on the proportion of patients with lacunar stroke, symptomatic lacunar stroke, who have hypertension. Just focus on a couple of details here. First, there are some variations in the proportion of small vessel symptomatic disease of lacunar stroke in different parts, different epidemiological studies, but also you see that there are high fractions of undetermined stroke, indicating that it's quite imprecise diagnostics, but roughly 20-25% in most studies in the western part of the world. In China, we have, for instance, this study indicating a proportion of 42%. So it may be that there are quite large variations in different parts of the world of proportion of lacunar stroke indeed. So hypertension, how important is it? It used to be said that to have lacunar stroke. It was always mandatory with hypertension and diabetes, either of these two or in combination. And we have a problem in subtyping because what you see here is the most popular, the most commonly used subclassification scheme, the TOES classification. And unfortunately, the risk factor is circuit evidence is part of the diagnosis that history of hypertension and diabetes supports the diagnosis that it is a lacunar infarct, that it is small vessel disease. And of course, this is silly because it's circuit evidence. What is a proportion with this definition? And this has been studied that if you look at studies with hypertension included in the definition, clear excess of hypertension compared to other stroke types. If you look at only imaging-based studies, you see that much of this excess disappears. So it seems that it's about the same proportion of hypertension for lacunar stroke than compared to other risk factors. But we also have problems here about how precise is the diagnostics of lacunar stroke, how precise can we separate the subtypes against others. Most studies have been based on CT scan. There have been different definitions across studies, and this is one important and recent study from Joanna Warlow's group showing the imprecise diagnostics separating cortical versus lacunar infarcts. You see a 23% misclassification here and a 16% misclassification in the other one, indicated that is quite imprecise, even in studies which are really of very good clinical quality. Another study showing even worse, that if you use clinical features and a negative CT scan to diagnose small vessel disease, you see that the positive predictive value is only about 40 to 60%, showing that it's very dirty, it's very imprecise, and we need to keep this in mind whenever we are thinking of small vessel disease, whenever we are seeing materials with lacunar infarcts. They are imprecise. They are, by present now, they are very imprecise, really. And we also have this other way around, that if we are patients presenting with a stroke and you see that there is a lesion in the subcortex that would fit with a small artery disease, does this always present with lacunar syndromes? No, this is also not the case. So it's another impurity that we have to pick up it by means of the clinical features. One of the most carefully conducted studies recently is a randomized trial on therapies in small vessel disease, the SPS-3 study. It's a large study initiated in the US, and it looked at antiplatelet therapy and blood pressure lowering in patients with small vessel disease. These were patients that were very carefully characterized at onset. Every patient had an MRI, should have features compatible with small vessel disease. I think this is the most rigorous clinical trial on small vessel disease, really. And what you see is that proportion of hypertension here is 75% in both groups. So I think it indicates that it's highly prevalent. It's really very common with hypertension in lacunar infarcts. I will move on to silent brain infarcts, another expression of small vessel disease. And here's a classical graph showing the proportion of silent cerebral infarcts in the population based studies. And what you see is that with increasing age, the proportion of patients in the healthy general population that have silent cerebral infarcts is very, very high. 1 out of 5, 1 out of 4, 1 out of 3 is really highly prevalent in the elderly population. Age is important, is unquestionable when we speak of small vessel disease. And the vast majority of silent cerebral infarcts are subcortical infarcts, or in essence, this is small vessel disease by the vast majority. Risk factor, hypertension, again here is the single most important risk factors. in addition to age. This is very clear from the studies. And again, here we have with silent cerebral infarcts, how precise is the diagnostics? We used to have this as a very separate entity in clinical studies. Silent cerebral infarcts, white matter disease, separate them from the acute symptomatic stroke as precise categories. What we know today is there is much more of uncertainties here than we ever thought of. We have one differential diagnosis, which you see here, the perivascular spaces, and I will draw your attention to this publication, which I think most of you have seen in Lancet Neurology, I think in June this year. Joanna Wardlow was a driving force on this together with Martin Dischkens and Eric Smith. And this is a very important paper with definitions of the imaging features of small vessel disease. It's a consensus paper, which also in my view is a landmark paper to really define what are we seeing, what should we label, what are the caveats when we are looking at the different subtypes here. And here is one of the slides from this showing how to separate lacunar infarcts from perivascular spaces and what the characteristics are of other small vessel disease MRI imaging findings. So do all symptomatic lacunar infarcts cavitate? This is what we imagine when we think that we see a result of a previous symptomatic lacunar infarct. We see it later on an MR scan, and we think that this must have been that from the very onset. Again, here you see that there is much uncertainties in this field. We need further studies, but it's clear that not all lacunar infarcts that cause clinical symptoms cavitate with time. And again, I would like to acknowledge, to recognize the work of Joanna Wardlow in this field, which is really advanced our concepts here and showing that if you have an acute infarct in the subcortex, a lacunar infarct, what can happen with time is that it can disappear, it can be invisible, it can turn into regions of white matter disease, or it can cavitate and emerge as a lacune. But there are several possibilities here. It's much less straight than we ever thought of this. And this is also depicted in this slide, again from this publication in Lancet Neurology. If we see a silent small vessel disease, small lacune in the chronic phase, it can be an lacunar infarct acutely, but it can be also many other pathologies give these end results. And that means that we are today much more cautious of what we see on imaging and what we infer, what was this in the acute phase. There are so many other etiologies, and we have to recognize this. We have pictures of this that very often patients with subcortical infarcts also have at the same time white matter disease. The more of one, the more of the other. But what we learn now is that there is really more of overlap between lacunar infarcts and white matter disease than we are recognized in the past. They are not clear-cut entities. There is an overlap between these two, which I think that we need to recognize. We also have the clinical caveats with silent brain infarcts. They may have been truly silent, but of course we know that patients can forget symptoms. They can have been minimally symptomatic. We know that the proportion of patients with a brief episode of TIA may turn out to have an ischemic abnormality, and we can have ischemic events during sleep which we don't recognize but turn out as a lesion. So of course there is a gray area here. So what is the distinctive feature? Well, the most important one is probably localization. If there is a subcortical lesion affecting the long tracts, it causes acute neurological dysfunction. If it is in silent areas of the subcortex, it does not cause acute neurological dysfunction, but it is not innocuous, it's not harmless to the brain, as we well known. And it's also been shown, the evidence we have so far, that the pathology of silent lacunar infarct and lacunar infarct causing stroke is the same pathology. It's the same disease. It's only the location that really matters. It's the same type of disease that we actually see. So I will briefly also mention to you that I have been involved now with WHO revision of ICD-10 into the new classification ICD-11. ICD-10 was produced more than 20 years ago. CADASIL is not part, it was not known at that time. There are so many other things that has happened in this 20-year interval. And one of the novel features of the ICD-11, I've been sharing this group at WHO, it's been very tough work and partly hard work, also political work, is that cerebrovascular diseases will emerge as one single block under diseases of the nervous system. That means that they will move from under the shadow of cardiovascular disease, move to diseases of the nervous system into one single entity, and with all the statistics, it will appear in separate columns. I think this is a major advance, and this will be the same also fight that I have also been part of, to have the dementia disorders under diseases of the nervous system and not under mental disorders. These are organic nerve diseases. And this is another new thing here. We have into this block, this category now, cerebrovascular disease with no acute cerebral symptoms. So here we find silent cerebral infarcts, silent cerebral microbleeds, silent white matter abnormalities associated with vascular disease. We have the definitions, but now it is recognized that this is not stroke by definition, but this is the framework of cerebrovascular disease. So it's one of the major changes really in the classification. Silent cerebral microbleeds, I will only mention very briefly. We have some population-based studies. You see the prevalence are quite different in these studies. This depends on the age groups included, if it's younger or more elderly patients. It depends on the MR equipment, higher proportion in the Rotterdam scan study, which had more precise MRI technique. And if you are going to analyze risk factors, you need to have a good study power. This is a problem in many of these studies. But again, you see it. Hypertension appears as a risk factor also for microbleeds, and also relation with lacunar stroke, also some relation with CADASIL, that if you have CADASIL and if you have blood pressure measured in different ways, it affects the expression, the phenotype of CADASIL and the clinical prognosis. Genetics also relate to stroke subtype and intermediate subtypes. I will just mention this very briefly. I think risk factors obviously are important, but we have lived with the concept there is a gray large area probably of genetics in small vessel disease in patients with lacunar infarcts. So what do we see in the most recent now GWAS studies on genetics in stroke in the different subtypes? Is it of importance with genetics when it comes to small vessel disease? This is a recently published metastroke, and you see one of the SNPs that turned out significantly for large vessel disease only, but not for small vessel disease. Another SNP here, significant for cardiombolism, not for small vessel disease. Yet another one, significant for cardioembolic disease, but not for small vessel disease. So large vessel disease, cardioembolic disease, we find a genetic component. In another study, chromosome 6p21.1, and here again you see when we go to subtypes, what falls out is large artery disease, which has this association within ischemic stroke. Another recent finding, the ABO locus on chromosome 9, again here you see significant association with cardioembolism, large artery disease, but not significant with small vessel disease. And another summary of the genetic loci, and you see that associations with large vessel disease, cardioembolic disease, but not with small vessel disease. And final slide on this is that you can also make an estimate on what is called the genetic heritability for a disease. You can do that by genetic analysis. You can appreciate what proportion of this disease or this subtype is potentially heritable or genetic. And you see for stroke overall, we can estimate that 38% of all strokes have a heritability, but if you look at the different subtypes, the one with the smallest genetic component, again, is small vessel disease. So what I've thought for many years is that there is probably much more genetics in symptomatic lacunar disease. What we now find from these GWAS studies in patients with symptomatic stroke is that no, small vessel disease does not really turn up to be a genetic, highly significant component. It is rather the opposite. Why is this the case? Well, again, it may of course be that this classification is dirty. Its contamination is not pure small vessel disease. We see is contaminated with a lot of other things. And published online in Stroke now is a SIGN project with GWAS studies with a much more precise subtyping of stroke, which I think is needed here, really. We know that some of the genes that we find are related to hypertension. We'll find a link with stroke, but is mediated by the link with hypertension. And I have just one slide here on blood pressure variability. It could be many because this turns up as a very, very important concept recently. We know that the diagnosis of hypertension is extremely crude to use a dichotomized yes or no for hypertension. It depends on the duration, it depends on the level, but it's also a profound variation between different types that you measure blood pressure. And it's been recently shown that perhaps the most important variable here is the variation of blood pressure itself rather than the absolute level. And I think this is of importance for sporadic small vessel disease. It's probably also important for patients with CADASIL, with blood pressure variations and fluctuations that we have with this small vessel arteriopathy. What you see is the difference here in one measurement and the other one, and you see that there is a huge variability, huge spread. You may appear to have a normal blood pressure at one visit, and you may be hypertensive, and another one is a huge fluctuation, really. So finally, the final proof, of course, of the importance of hypertension and increased blood pressure is if you treat it, does it produce clinical results? So we have some results in this area. Here is from the PROGRESS study about 20 years ago. There were some studies, one showing that the CT sub-study, there were no significant effect of blood pressure lowering or rate of silent cerebral infarcts over 3.9 years. We know CT is imprecise, it's a quite short period. There was an MRI sub-study showing that blood pressure lowering stopped or delayed progression of white matter lesions, so at least some hope. And now to put the circle back again, here is a SPF3 study that looked on two blood pressure targets, normal blood pressure lowering and a very intense blood pressure lowering. They worked extremely intensive to have the patients under tight blood pressure control and below 130 milliliter for the lower group. They succeeded to make that over several years, and the result was, which you see on the next slide, it was P 0.08. It was not fully significant, unfortunately, but almost. So there is a suggestion that lowering of blood pressure may improve the prognosis after lacunar infarcts, and it decreased also the rate of intracerebral hemorrhage profoundly by more than 60%. What we do not have on this slide, and we do not have the results yet, is the effect of cognition. And I think we need to wait for that. Blood pressure lowering, it reduces the events almost significantly. If it also affects cognitive effects. This is the most important thing, that we need to look on these two in combination, I think. So some hope that blood pressure lowering is of importance. Endothelial dysfunction, synergies with hypertension, I think this will be dealt with elsewhere in this symposium. So my conclusion is hypertension important? Is age important? Well, absolutely yes. These are core risk factors for small vessel disease, for stroke, for all types of stroke, wherever you live and globally. We need to recognize that small vessel disease ischemic phenotypes are never pure, always contaminated. Dichotomized definition of hypertension is oversimplified. Blood pressure variability is at least as important as blood pressure levels. Genetic component of lacunar stroke appears smaller than for other stroke types, but with some caveats. And hypertension plays a key role in all aspects of small vessel disease of the brain. Thank you.